Good morning, everybody. I know it's a bit late. I'll try to be as fast as I can. Congratulations for the elite meeting, Dr. Muhammad Sohi and the organizing committee, and thanks for the kind invitation. My second case is not as scary as Yasser's one. It's not always the obstructive valve. This was a 76 years old male patient who had diabetic and hypertensive. He presented to us with exertional dyspnea near class 2 over the last 4 months with history of acute pulmonary edema 2 months ago. He had an echo of normal ejection fraction with severe calcific aortic stenosis, moderate pulmonary hypertension with a mild mitral regurgitation. And we had a heart team meeting that was in favor for TAVR. You can see that from the multi-slice CT that we did before proceeding to TAVR that the patient had a shallow. He had two problems regarding his coronaries. The first is that the right coronary artery was low-seated. It measured about 7.3 millimeter above the annulus. So this is a low-seated right coronary artery. The other point is that his sinus of Valsalva width at the level, especially opposite to the right coronary artery, was shallow, measured around 23.5 millimeters. For those who are not acquainted with the TAVI procedure, what's our concern here? That after putting the valve, after implanting the new valve in the aortic position, the right coronary cusp could be displaced if the sinus of Valsalva is not spacious enough to accommodate the displaced leaflet, and there is a risk of right coronary artery occlusion. So what we do usually in such cases is that we do balloon aortic valvuloplasty to look how would that cusp behave with the balloon aortic valvuloplasty. Would it cause a coronary occlusion? So we do a balloon angioplasty together with a simultaneous aortic injection. And if the coronaries are at risk, we go for coronary protection together with the TAVR procedure. So this was a CT and this was a coronary angiogram. He had an insignificant coronary artery disease with 40% proximal LAD and a 40% proximal right coronary artery. And now it's the panel discussion time. What should we do? So anyone is having any concern before proceeding to TAVR procedure? My question is, who would do a routine balloon aortic valvuloplasty for this case with a low-seated right coronary artery? Nobody would do it. Okay. So we did, this is aortic, a pigtail with aortic angiography with, and then we crossed the aortic valve and the stiff wire is placed in the left ventricle. And at that time, we were planning to do TAVI with a Sapien XT26 according to the aortic annulus measurement. We passed the balloon. Immediately after passing the balloon, the patient arrested. Even before balloon aortic valve, before inflating the balloon, the patient arrested, had a ventricular fibrillation. We started resuscitating the patient, and while they were doing the resuscitation, I went with the balloon aortic valvuloplasty to improve the hemodynamics. And after a single DC shock, 2 minutes of resuscitation, the patient is back. So what went wrong? Any suggestions? Why should that patient? Yes, he had a VF. Immediately was trying to cross the valve with the balloon before even inflating it. VF, yes. Excuse me?
It could be induced by ventricular excess.
Okay, the wire itself could have some left ventricular. Okay. Um, but we didn't inflate it yet. The patient arrested before inflating the balloon. So what I did is, while doing resuscitation, I went with the balloon inside and I inflated it while they were resuscitating the patient. But the patient arrested already before the balloon inflation.
Yeah, but this is not unusual. We see sometimes this happening. The aortic valve area can be 0.5. So if you place a balloon inside, becomes 0.1 or even 0.
Yes.
So you basically occlude the valve.
Yes.
So it's not a surprise. I think you confirm that the patient has critical aortic stenosis.
Yes, exactly. Yes. So after the patient was back again, we decided to go as we previously decided to do simultaneous aortic angiography with the balloon inside to check that there is no coronary occlusion with the displaced leaflet. But what was really interesting that there was a staining in the right coronary artery. So what happened? We decided to go for a selective coronary angiography, the guiding right, Judging right in the coronary ostia. There has been acute right coronary artery occlusion. Probably there has been part of the calcium or the debris on the aortic valve that embolized into the right coronary artery. So we decided to go for a PCI to the RCA. That was a hydrophilic PCA wire advanced into the distal RCA, and then we took a 2.0 15 balloon, and then after inflation, you can see there is something obstructing the right coronary artery right here. We tried to advance a stent. The stent stopped exactly at the site of the complete obstruction. And then we decided to take a larger balloon, a 2.5 balloon, and after inflating the balloon, we had a TIMI free flow in the right coronary artery. So we decided not to put a stent and to proceed with the TAVR procedure. And this is 26 Sapien XT from Edwards in the aortic position, and that was rapid pacing, valve deployment, and the final result, and you can see there is a very good filling of both coronary arteries. The patient was extubated immediately after the procedure. Post-procedure echo showed a normal function with no segmental wall motion abnormalities, well-functioning prosthesis with no transvalvular or paravalvular leak. So I do appreciate your comments.
Is it common to have debris like embolization going to the coronary with the balloon?
Not common, the first time we see. So dramatic. Congratulations. Two excellent TAVI cases. The best for the you saved the best for the lady.
So why need with a wire really just for the you have an accent in the right coronary. You clear the right coronary, but during deployment of the valve, why do you do a wire in the right coronary tract? The new technique nowadays putting wire in the coronary while you deploy this.
So in case we suspected or had after during the balloon aortic valvoplasty, if we saw that there is risk of coronary occlusion with the displaced leaflet, we put even a stent in the coronary at risk, so to withdraw it after valve implantation in case there has been a compromise of the ostium of the RCA. But in that case, we did a balloon aortic valvoplasty that showed that the ostium is patent, even with the displaced leaflet, so we thought that we don't really need to leave it. Yes, exactly.
Okay. I think, thank you very much for this wonderful piece.